Hello. Oh, yeah, it's working. I gotta lean into this there. Oh. I think this is it. All right. If everyone would please rise, and those that are covered, uncover. Join me in a pledge of allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Wonderful. Thank you. Hi, everybody. Welcome. And screen's looking good. Cool. Want to say thank you to everybody that's online. It looks like we have probably 8 or 9 folks tonight. Mr. Hurt. I know there's quite a few. So those that took there's 9 screens. Okay, so we have 9 folks at home. Welcome, guys. Glad you took the time to check in with us tonight for the meeting. This is going to be short and sweet from my side. We're going to do some testimonials tonight. Hopefully, from the folks that went down to Anniston, get a little briefing on that from their experience with the new and refined fundamentals. Dr. Roberts is geared up tonight for a presentation on a potpourri of topics that were submitted from everybody electronically by emails earlier. So we'll start out with the HQ. I can tell you nothing new, nothing's changed. Same old folks, same game plan. There's been no movement in any direction regarding hiring freeze. Nothing's changed. It's been relatively quiet. Communication has been pretty much focused on changes in payroll, processing, AO stuff. They keep narrowing down the AO scope of control. So Kathy's feeling a little neglected, beaten, and abused. But other than that, there really hasn't been any major upheavals from Washington. The training schedules are out for 2016 for fiscal. And I hate to have to tell you guys, but we didn't win the draw for the RNC or the DNC, either one. It wasn't our month on call. So, but there is a United Nations summit that we are scheduled to be one of the contingency teams for. So there's a high probability. I know there's 16 teams that are on that contingency, but a little bird said that we should be prepared to engage in that. And that means we'll either be on site or we'll be in Frederick training. And if we go to Frederick training as a contingency team, we'll be setting up a booth and living in it for a couple days. So the UN General Assembly, well, copy of the training calendar. Here we go. I can tell you. Well, that's the training calendar. Let's see. And UNGA is in September, and there are no dates on this distribution. It's between September and October, so I'm assuming it's obviously September is our month, and that's why we're on for this. But it's the UNGA contingency team. So I get more information on that. I'll share that out. But it's for those that have the training schedule, Jeff. It's at the far right. Okay, cool. So that's the only thing that we really have in the works, I think, as far as training goes. Andy is going to be representing logistics and going to Anniston in April. They're having a safety officers training session in Anniston, but we don't have anyone in that PD, so we don't have the ability to send anyone to that. The commanders retreat is going to be in the heat of August in Phoenix again, so I'll be out there for a couple of days as we all go in to hash it out with HQ once again. But that's a preview of coming distractions. So I will reiterate once again, we're on call March, June, September, and December. We just finished the March roster. and we had to use backfill for one physician, half a PA, a pharmacist, and another half a pharmacist. And those are our Achilles heels. This is getting to be consistently consistent when it comes to our ability to roster. You know, we're just light. We're light on docs. We're light on mid-levels. We had a nurse practitioner that was going to transfer in from California 6. I've been working on trying to make that happen for the last 2-3 months. Finally, I did the paperwork. I sent it to him to send to California to Jake Jacoby. I got a phone call the other day that they had forced the guy into a resignation last April when he said he was moving back east. They didn't encourage him to stay in NDMS. So he goes into the hiring freeze hell. So we weren't able to bring him on board, which is unfortunate because he was ready and raring to go. He just started a new job over at Cleveland Clinic. So we missed out on that because he didn't realize he was signing a resignation, according to him. So, he goes to the back of the room, back of the class. But he wants to stay actively on our hiring list for when the day comes that the freeze is ever lifted and we have the ability to hire mid-levels again. He wants to come back on board. So let me get into my mail here and we'll look at, come on, out. See, other training opportunities. TEACS went very well. I think we kind of chatted about that. The class was excellent. We had 71, 72 people, I think, that attended from Indiana, Michigan. We had state government people. We had hospital folks. We had DMAT Michigan, DMAT Indiana, and a scattering of a few other people tossed in for good measure. It was an excellent course. I did not hear any negative feedback from the course per se. I have been in touch with the guys from Indiana. We had 2 people from the Indiana State Department of Homeland Security that attended the course. And because we've been kind of backdoor trying to partner with Indiana as they were trying to move forward to become a federal DMAT, and they got 86th out of the system with the budgetary restrictions, constraints, and so they were told that they were not going to have any more developmental teams, and Indiana got tossed out. Well, Indiana has been pursuing developing a state DMAT, and they figured out how to make DMAT folks intermittent state employees, which is really pretty interesting. And so they are in the process of building up their team. And because we've been involved with them, and Mr. Andrianopoulos, our former REC, the rec up in Chicago, Carl Andrianopoulos, some of you guys know him because he came to our chili cook-off. He's retired, and we have a new rec up in Chicago now. And I met him out in Phoenix last summer, and he's a young Turk. And he's like, you know what, we're going to make some training opportunities happen for OH-1. So Indiana reached out after the TEACS class, and they have an opportunity. They would like us to come over, and we got to figure this all out, honestly, but they would like us to bring some folks over and get our USARA coverage and come over and show them what a DMAT does. They have the equipment. They have the Western shelters. They have caches that they've built up, but they have extended an invitation as a result of the TEACS course to come over in August, and we'll talk about this more in depth. But I think this is a great opportunity to go play. Obviously they want to do a weekend gig. They bought a town in southern Indiana, south of Indianapolis. It's kind of like it's a response town, and they have a hospital down there. They have collapsed structures. They're doing all kinds of stuff in Indiana down there. The SWAT people are working out down there. The Seaburn people are down there training, and they want us to come and play. They want us to come and help their folks learn how to do Western shelters, show them what we have, because they've heard nothing but rave reviews about this team from FEMA and also from HHS up in Chicago. So as we get a little more information, I'll share it around so that you guys can toss it about. I'd like to see some people go over. I mean, obviously I'm going to go down. And I'd like to have enough people that we could go down there and at least maybe show them how to put up a tent and show them how we do triage DMAT style, kind of give them a little razzle dazzle, because that's what they're looking for. And they were so impressed with the folks that they met, and they pretty much worked the room. They met pretty much all our folks. They talked with the Michigan folks. They were kind of subtle. They were a little quiet about it. But it was interesting to hear their feedback, and they were just so impressed with all the people that they met coming over here to play, and they want to come back and do it again with us if we extend out and get other TICS courses in here. And Jeff will talk about that too. But we made some new friends over in Indiana, and they want to extend the gratuities back by having us come and play. Speaking of playing, we have the trainer coming up with the 180th, and that is going to be in May. And they are refining their agenda so that they're going to have an all medical train day on Saturday of that weekend. And they are talking about, of course, now they are saying they want to fly, which I just said I can't even talk about it. So they're going to do some hostage scenarios on one of the C-17s. We're going to have military SWAT. You're going to have civilian SWAT. We're going to have all kinds of folks out there playing, doing all kinds of stuff. This is the planning this year. I look at the spread of all the people that are on this, that are involved in this planning thing. It's 5 times as big as what it was last year. So, that is going to be something that we'll probably want to fire up and do USARA for and go play again. I talked with Michigan. Michigan was going to do their weekend with us at Camp Custer of Battle Creek on that weekend. And they're going to postpone that and shove it out to fall because they want to come and play and do this, do a return visit with the 180th and the Air National Guard. So, yeah, I might. I was thinking it was, hold on, wrong email. Let me go back one more. No, that's fine. I had sent that one around, but here we go. Wait, the trouble's not in your set. Stand by. Oh, no, it's just a huge email that's not going to download because the bandwidth is too small. Sorry. I'll send you an email again. I'm thinking it was like the 11th through the 16th. Does that sound about right? It's the right weekend. I know the 11th is involved in it. It's going to be like 5 days. We're invited in for one. We're invited in for the medical day, but they're going to be doing stuff with the state EMA. They're going to be doing stuff with FEMA. They're going to be doing activities with, I think the Army's coming in, the Marine Corps is coming in, Naval Reserve's coming in. I mean, they're going to be doing stuff. Crash fire rescue is going to be drilling. The payload people for logistics are going to be playing just like they did last year. That was it was supposed to be 4 or 5 days last year, and I think they narrowed it down. That window was down to 3 or 4 days. They're expanding the window this year so that they can do more with more people. So I will send an email out to everybody with the exact date for the Saturday with the 180th, so that if those that want to go, we'll do the same thing. We'll file the paperwork for you, Sarah, get all the safety stuff submitted and everything just like we did last year. And then we'll start building a list because they're already asking for numbers, which we're nowhere close to being able to do that. And that's what I told them. So I'll probably get this prioritized. So if you all would respond as to whether or not you think you might want to go, because I know that list always shrinks by 40%. I can at least give them an estimated number from here, and I'll forward that up to Michigan 1, 2 to Tony so that his team can weigh into, so we can try to at least give them a guesstimation of what our participation count may evolve into. Okay, well, let's see here. What else do I have in my happy little list of good stuff? Scotty's been sending around some really neat stuff from CDC. I guess you're going to talk about Zika? Okay, good. I hope you guys are, I don't send every daily brief out to everyone, but I tell you what, I've been reviewing them and scrutinizing them very closely the last month and a half and watching the Zika, which it's mirroring what happened with chikungunya fever a year ago, except this has obviously far more serious ramifications. At least it has the attention of the World Health Organization and everybody else all screaming and running for the hills. So Lisa's going to talk about that tonight. I would say, just encourage you, when I send out the briefings, I'm hand selecting them, and generally the focus of those for your attention is to look at what is evolving with the Zika virus itself, how fast and rapidly it's spreading, not only in our hemisphere, but now we've got human-to-human transmission. It's significant. Just kind of pay attention to that. I try to send at least one of those out a week from the dailies so that you guys can kind of see that. But I would keep an eyeball on that because it's evolving very rapidly. The recommendations are changing very quickly, and it's going to be in our backyard before you know it and they've already proven that air transport is spreading the thing like crazy. So, and we do have the Aedes aegypti mosquito here. So, a couple things to just keep in mind as you're looking at that. But the primary reason I'm sending those is because of the Zika. Let's see. So Scotty did send out some CDC interim guidelines, and I did send those around. I hope some of you took a look see at those. If not, if you need it, if you want them again for personal reference or for even for sharing with your friends and cohorts at your institutions, just drop me a note. I'll resend this stuff out to you. No problem. Our federal equipment status. It looks like we have tri-walls finally delivered to Jerry, so we're finally going to be moving our federal equipment from here out to Texas, so we'll be relieved of that. Finally, it's been a year process just trying to get that thing all pulled together. So we will free up the space that we've been occupying here. And again, I've sent many kudos to the college to thanking them for facilitating us. And I also sent them a real nice letter thanking them for the TEACS accommodations using the CEP. So that being said, any questions about from a command perspective that I can spread light? Not. Who from Anniston would like to be the first to come up and start sharing your experience? I think we have 2 people here. A or B? Who wants to go first? All right, Kathy's coming up. All right, we're gonna take some time here. I want Kathy and Beetlejuice to talk about their experience at Anniston for fundamentals training. Some of the photos that are coming up, they're not all blurry like that one, kind of reflect their trip. So, Kath, come on up and share your. Oh my God, Kurt Koenig with sleeves. Okay.
We had plenty of TP, so he was all right.
There you are.
I don't think I need a mic. Everybody can hear me. They'll hear me too. I'll use my teacher voice. That's us with the director of MDMS. He was there for a day and a half, so we all got to chat with him if we wanted to. This is where we had our classroom skills training. You'll have to help me, Paul, because I'm not sure I remember every station. We did Zols, we did fit testing, we did a lab, and the cache that we had was the one from Texas. So it is exactly what we would get if we were on deployment. We also did stretchers and set up cots. What else did we do besides those?
All had new stuff in it.
You got to come next to me. Sorry.
The cache had all the new stuff in it. So the new monitors, there's a new Zoll monitor in there, and other things that were in there. We got to play with all that stuff. It was interesting.
That was Anita. We won't tell any tales because what happens in Anniston stays in Anniston, right? It's really excellent training. If you get the chance to go, it is outstanding. We did, death by PowerPoint the first day, but after that, we did the skills things, and then on Thursday, it was a 4-day event, plus your travel. On Thursday, we went and set up a boo. This was us in the freezing cold, because you think of Alabama and you think of it being warm, but it was in the 20s and 30s when we were setting up the boo. We had the guy that's the national representative from Western Shelters, so he went through exactly how it's supposed to be done, and it went up very smoothly, I think.
Yes.
We had no problems and learned some tips on how to get it up appropriately.
I think we had all the shelters up within 1 hour, and there was 4 of them.
We put them up once, took them down once. We put them up on Thursday, and then we had our ICE experience on Friday, where they had 110 victims come through in about 3.5 hours. There was an earthquake, and everybody was a victim of the earthquake. We had a lot of fractures and lacerations, and people had stepped on rusty nails, dislocations, all that kind of stuff, burns, those kinds of things. That looks like, I'm not
Less
sure
than
that
toward
was,
the end of it, they had people with possible organophosphate poisoning. They kept messing with us.
yeah.
Just by the time
And
we thought we had everything calm and collected, we had everything down, here comes another crew with something different.
we had 2 power outages while we were in our ice, and they were not planned. They were something that happened to them that they were surprised about. Oh, that's me. And Anita. It really was, I think, a very, very worthwhile experience. Even if you had trained before, we did suggest to them that they're having the works looking at a fundamentals 2 or a more advanced for people that have had lots of experience. And it was nice to have those folks with experience, of course, to lend their expertise. But it was difficult when they would forget about people that were new and didn't have much of that experience. EHR was another station we went to in skills, and we did that twice. And it was a PIA because whenever the electricity went down, of course, we had no computers either. And so they did have to break out the paper, even though they didn't want to. So we were running from paper back to EHR, back to, just like a real thing. And
the biggest thing was the public health system people that were there. There was 5 of them.
yes,
Or 5.
from
They were
United
surprised because they said, I don't know how you did this. When I got tired, I looked at you and you looked like the Energizer bunnies. So I just kept on going.
Yeah, they were all, one of them had decided to take over the pharmacy role, even though that was not her natural role. And she just couldn't believe that everybody just kept going. It just kept going. And you just kept going, just like you do. And they had real actors besides the dummies that they brought through that were really quite good. I mean, we had one that came in, she was HIV positive, and she kept saying, I'm going to share my AIDS with everybody. And I mean, they were really good at what they did. We had some people that were hysterical, and they would be screaming for their pain meds, and you know how long it takes to get the order into the electronic record and then to get the pharmacy to fill it, and etc. So it was very real, I thought, for a simulation.
They had a actual wheelchair person found.
Yeah.
And he came in twice. First time with a fracture, second time he was blind. So he had to use a puffer to get around. He was very good at it.
We had another one that came through that was deaf, and another one that came through with his service dog. It was not a real dog though; it was a stuffed one. But yeah, they tried to send some of the disability things, or whatever we call them now, through. We had, I don't know where the team came that was transporting people, but they were obviously told to do nothing but take people out the door when we said they were ready to go, because they wouldn't help with anything. Didn't matter what. They just did what they were told to do.
I think they were logistic people from DMAT themselves, because they were in vests separate, and you give them a wheelchair or a gurney and it disappeared. They might have been.
They didn't identify themselves, but they had vests on that we knew that they were the transporters. But
well, of the 5 that went from this team, only one that was new. That was Dave, and we involved him in everything and anything, and he enjoyed himself. He really got a good experience to go out the door.
right, since he's in Chicago, he's a hard worker. He'll fit in just fine. He is top notch. He went into the red tent, and you'd have never known he was new. Yeah, very, very good.
and we hammered the red tent. So I was on triage, and I know exactly what we did. We probably had 10 to 15 out the door when they first started coming in. And at normal triage, you just get bits and pieces of what you need to know and go and get the next one out. Get the tents working, and that's what we did. People are looking at me, I haven't given you anything. 90% burns. That's going to go to red. They're going to die, but they need to go to red. They're not going to yellow or green. Just give me 1 or 2 words, and away we go.
They did have a couple deaths in red tent to have to deal with. It was, I thought it was set up very well, like all the things that they do in Anniston. It's very well done. We've had some suggestions for them, quite a few actually. Well, Anita and I had dinner with the director and his associate. I don't know what his title was exactly. And he was interested in some of the issues that we have getting out the door. And we shared with him that, A, people don't know what NDMS is. They don't know what DMAT is, for the most part. And so it's hard and harder and harder to get new people onto the teams. There was a lot of discussion when he was talking with the whole group about hiring. And his position is that he wants to be convinced of the need. And so that needs assessment is important to him. He's not just going to automatically replace one for one. That's his position. He wants a needs assessment to prove that we need those people. He also spent a lot of time on why you can't work as a nurse when you're out as a commander, and why Jeff can't work as a paramedic, etc. All that. That's a federal law that says you cannot do that. And it's not just NDMS, and that's why he can't change it. It's across all the federal employees. Once you're hired in a position, you can't go out of that role for that position. No, he pretty much, well,
didn't make any difference.
It didn't make any difference. As far as the federal government is concerned, if you're hired as a laundry person, that's it. That's all you can ever do. Exactly. And you have to leave that position and apply for a new one. And his thoughts about, he doesn't want a lot of nepotism going on in slotting people in. He wants legitimate, open up to everybody. You apply for the position if you're the best qualified. And yes, then you can get it if you're within your own team. But he doesn't want the automatic promotions or the field promotions, that kind of thing. We had a lot of those during the exercise. But we spent a lot of time talking about uniform. I'll have you know that we were the spiffiest looking group, I think, there. We had our patches and we were all to go, and there were some really ragtag looking folks.
And our pants were tucked in.
We were
to some of the other ones.
100% on. He likes the khaki undershirt thing. He's fine with team shirts. He really had no problem with that. And he's not very prescriptive about them, because one of the big complaints everybody had was they don't like wearing a sticker or a piece of tape on them telling who they are and what they do. And he's fine with us putting nurse, medic, logs, whatever, on the shirts. He didn't have a problem with that at all. But he really had a problem with Tennessee's orange. That was blindingly orange. They had new shirts, obviously, for this exercise, and it was blinding. Yeah. But yeah, he's a very personable guy. He's got a lot of opinion that he feels very strong about, which I'm sure you know from talking to him. And anyway, we were talking about how even though USERA says that your employer has to let you go, that's not always something that happens easily, and people get flack for that. So he wanted to know what he might do to help that. And as the conversation evolved, we said, that because it's not known and because the employers don't really want to replace you, and that's the bottom line behind it, that's where this idea came up to do letters to the employer, thanking them for sending their employees to the disaster, to letting them deploy, and just making some marketing, if you will, with those letters. So that was supposed to happen with this deployment. All of us that went gave our names and our bosses' names, and he was going to draft a letter and get those sent out to our employers, thanking them for letting us deploy. Mm-hmm.
And all the hot wash items that was brought up, which was well over 2 hours worth, was going to go back, and on this next fundamentals. All those items are trying to be impeded into that. There's one of them came up was setting up the tent, setting up so many boxes for red. So those crates, when they come off, they go into red, they're ready to go. So when they're empty, red's ready. Instead of spending, we spent almost 3-4 hours.
We got the tents up faster than the equipment. You know, we could not get, there was 109 of them, I think, or something like that came off the trucks. And, you know, it was massive for all the tents to go in and try and get what they needed, because some of everybody's stuff was in 101, 102, 103. And even though you had a list, it still took forever for us to get that and try and setting up our tent. And so everybody really felt strongly that coming off the truck, there should be a certain designated boxes that go to the various tents, and that would help you get set up much, much more quickly. And then you can get just enough to get you started. And then, you know, you can fill up from there from the logs people. So whether that happens or not, we don't know, but a lot of people felt that way, and it was a strong recommendation.
One example of it was triage had 5 to 6 adult blood pressure cuffs, and none of the other boxes of the other tents had anything. They were coming to us trying to get blood pressure cuffs. They had maybe one, and we had bundles of them. We were in triage. It's like, what do we need that many in triage? And so we were passing them out.
And we didn't need to spend time on getting some of the equipment that we had, like a speculum and some of those other things that were supposed to go in the yellow tent. That's where I was. We just needed, you know, some boxes of gloves, some things for bandaging. We didn't need 50 IV starts. We just needed enough to get started, enough, you know, 10, whatever. So you could easily do that on a smaller scale for each tent. That happens.
And those ideas were written down by the people that was taking notes. There was 2 of them, and they were going to take that back and do it. We also said it should be an extra day, because death by PowerPoint needs to be split. And we need to get with the different teams to make 50. But they were surprised how 10 different states roughly, so it was 5 from each state, got together and worked as one team without even knowing everybody. And we really didn't know Tom, Dick, or Harry what they did. We did that the day of Friday morning. That's all we had, and that was it. What are you, a medic?
We never had time to get to know each other really when we were setting up our tent, because we were spending time in all those crazy Rubbermaids to try and find the equipment. Once the patients come in, once the patients came in, it was just, you know, you just clicked into your clinical, and it was interesting that everybody there was clinical. So we had a lot of people out of their normal comfort zones, out of their normal roles, doing things.
But Ohio stayed up to the motto, razzle and dazzle.
Yeah,
That's what we did.
I think we represented the team well. Thanks. Sure.
Well, that was a combination of all of us. They'd send them to me, and I downloaded what they had.
Test, 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 test.
So there's a few left. We've gone through 200 so far.
How much are they?
250.
$250 a piece.
So I'll be ordering more, and these are, I only ordered them like cash out of my pocket. Y'all know what I'm saying? want to wait to do it, know the process, email me. And I'll mail them back to you. That's all it's been. 6 months.
Okay, we're going to talk a little bit about training. The class we had here at Owens at the end of January TEACS, we had 70 folks from Michigan, Indiana, Ohio. We had some Ohio 5. I don't know if we had any Ohio 6. I don't think. Yeah, had 5. Michigan came down. We had some folks from Indiana. So very well attended by us. The instructors was very pleased with us. They said that had to be one of the biggest classes that they put on. So they was very, very pleased with our participation and the attendance that we had. We also met with the instructor, John. He is the lead instructor for that class and a couple other ones. And so we made a very good friend. Hopefully, they're talking about they're going to do some pilots on 2 new courses. So hopefully they'll use us as a pilot for one or both of the classes. I just sent an email out to TEACS to get another one as a medical emergency, so for a CBurn event. This time they'll actually will bring, I've done this course before, they'll bring in pediatric and adults mannequins that actually will kind of talk and they move and they blink their eyes and they breathe. They do everything. So they'll bring in, however many sets that we need to do it. So we'll get a lot of hands-on with that. And we're hoping that I'm trying to get it set up for January again. I think that worked out a good weekend to do. So with that aspect, there's some going there. We've got the 180th that's coming up. The things in Indiana, the weekend event in Michigan. So we got a busy year as far as training aspects. I said something on my mind and I was going to talk about. And they must be because I'm retired now that I'm starting to get dementia. That's right. I appreciate everybody. Oh, I know what it was. I want to thank Mary and Kelly and Anita. They did an excellent. Kudos to them for helping us out with the meals and the lunch for the TEACS program that we brought in January. It was a fabulous weekend, and they was a huge part of it, and it couldn't have been done without them, with their help. So I want to give them kudos for that. I think I gained 20 pounds that weekend again. Besides that, I think everything's moving along. Next month, we'll have to figure out what we're going to do training-wise. I haven't got to that point yet, so hopefully we'll get something. If not, I should be here, so I'll do it then. Anyhow, that's it for training. Unless anybody got questions. I don't see. Yes, Scotty. Did you? You're an overachiever. Scotty wants to know if anybody read the material. I'll have to disagree with that. There may be teams that don't have it. That's what, when we went to Haiti, is that the first teams and stuff that went in wasn't very pediatric friendly. But once they realized they had pediatrics, what did they do? They start going out. Yeah, they start going out into the other teams. May not bringing a whole team, but if, like, say, we have a couple we have a pediatrician on our, yeah. ICU nurse. So, you know, we may not be the whole team, but we have a couple people that we can send in to supplement, you know. Right. Correct. They're correct in some point, but they're wrong in other points because we, as across the nation, we can grab those folks and get them deployed and get them in the theater. Right. So. Well, it depends. Well, I know Toledo does. I mean, Toledo is a pediatric hospital. These is a pediatric hospital. We bring it back, you know. Yeah, but you get Memorial. I mean, you work down there. You get peds. Yeah, right. So,
I mean,
we're fine. Chris, we're fine.
I hear.
I appreciate your input, Scotty. And you know what? I don't always agree with everything that I read either, but I know that's been the sentiment, and that was one of the take-home messages from the teach course too. Was that
Right.
hey, you know, most entities are.
I do agree. We believe you, Scotty, and but I do believe there is some point we could do better as a whole in disaster aspects for pediatric, and that was a take home. We could do better, you know, aspects like that. So we got to have 16 hours every 3 years for pediatrics, or not 16. 8. No, it is 16. I think it is 16. But anyhow, you know. But it's still, we could do better. That'll work.
I'm not done reading. I'm just for your sake.
You're an overachiever. Send me the cliff note. Scotty's going to read the material from Teak, give me the cliff notes, and I'll be able to study it at night. There'll be a test next week, next meeting, right?
I just find that stuff.
Yeah. Zika. That's how it gets transmitted. And yes, yep. Doctor, I don't want to steal Dr. Roberts' thunder. No, heck no. So, all right. Any other questions? We do have a couple folks that are, yeah. So I have to come here with the mic so you introduce, because we got people online. Oh, you got it. Introduce them, Scotty. These are Scotty's cohorts.
I received an email from the emergency manager at the hospital I work at, from Toledo. And Michelle is a supervisory nurse in our cardiac step down unit. And she's also RN, BSN, MSN.
And an all-around nice guy. No, I'm kidding.
And Lindsay's also RN, BSN, MSN. So, maybe they could help with getting nursing CVs for our team. So that's their forte. So.
Welcome. Hopefully you're interested. We'll get the open slots open, and we'll get you through the process. Hey! I know we started the process a couple of years ago. We kind of dropped it. Those who need ICS 300, 400, and that's a requirement to be on the TLG, to be in a leadership spot. I'm getting back into it, so I know where the courses are. We can actually go to Ohio EMA website. There's plenty of courses to get you into and aspects like that. So let me know. Yeah. Besides that, I'm done.
Yep, that one, please. Thank you. Did you tell him to leave? So this is going to be on the footer of all of the OH-1 emails now. All it is basically is the roster of everyone that's there, and if it's turned in. So you don't have to log into anything. You don't have to look through our emails. You'll just be able to click, and you'll see where your status is if you've got everything turned in. Obviously, it's really small for everyone that's reading into here. It's not just you, but so it's updated. There you go. So it's updated, every 5 minutes. So it'll be a quick where you're at. The first column is how many meetings you've been to, and then all the other forms are there. If once I have a due date on them, we'll put them on there. At the very bottom, it'll say how many days till then as well. So yellow is like if you pick one, or Charles, it's not due yet till the end of the month. So he's yellow that something's due, but it's not overdue yet. So red means that you're overdue on something. And then obviously green is you're all set. But the point is just you don't have to look through everything. You don't have to find, you get a real time where you stand, what you're missing, without logging in, without looking at all that stuff. So when you get any email, like how in your subject line, it says OH1 in brackets. At the very bottom of that email, every single one of them, there's a link that says click here for your status. Click on it. It opens this up. You don't need to log in. You don't need Gmail. You don't need anything like that that's in there. Also in the footer right underneath that, there's another link that Google puts in there. If you ever want to look at any email that has been sent out through OH1, you can click on that, and it shows you every email too. So if you lose one or you can't find it or something, it's all in there. What's that? Yeah, the footer. Yep, the footer of all the emails. Any questions? Is that too easy? We can make a password if you want. All right.
So as you can see by Andy's little chart here, there's a lot of red in the one column. Those people haven't gotten me their medical clearances yet, and I wanted to get that in before we take our break, just because if they're not in and March comes around, you will be pulled off the deployment roster. Flat out, you will be pulled off the deployment roster, even if it leaves us an open hole. So those need to get in. Those of you who haven't gotten them in, who have given us availability, you need to make sure you have your medical clearance in, or you will not be rostered, as it's a requirement. So let's take a break, and then I'll do the lecture after that. Unless anybody else has something before. Okay. All right, can you guys hear me? Why don't we get started so we can get out of here? I asked for some suggestions on topics, and I got a bunch of little topics and then a couple of more extensive topics. So I decided to do a couple of the small topics since they otherwise wouldn't make a real good full lecture, and I kind of put 3 topics into one big lecture. So we're going to start with the Zika virus. Prior to 2015, the Zika virus outbreaks occurred usually in areas of Asia, Africa, and the Pacific Islands, okay? You didn't see them anywhere else. In May of 2015, the Pan American Health Organization issued an alert regarding the first confirmed Zika virus infection in Brazil. Now, if you look at all the concern, a lot of the concern comes out of some abnormalities with babies and births in Brazil. And this is why it's all of a sudden hit a big worldwide topic. This is the mosquito that carries it. Go to the next slide. It's spread by the bite of the Aedes mosquito. They are aggressive daytime biters. They can also bite at night, however. Okay, so you have to be covered up daytime and nighttime if you're going to try and prevent transmission by getting bit yourself. It's found in some areas of the U.S., and it can carry the Zika virus, but none of the current U.S. mosquitoes are known to be infected. They haven't found any actual infected mosquitoes as of the most current data coming out of CDC in the United States. Most of it's been transmitted to the United States from bites where people got it in other countries. They're found throughout the tropics, so the outbreaks will likely continue. So this is a map, and it's showing you where there's reported active transmission currently. And as you can see, it covers most of South America, most of Mexico, all of Central America, and a good portion of the Caribbean. So in pregnancy, the concern is that it's linked to microcephaly, which is a birth defect. There is some evidence that this birth defect may be related to some pesticides being used. There's really no concrete evidence out there exactly what is causing this yet, and that's the biggest concern is there's been a large uptick in the number of babies born in Brazil, specifically in an area known to have this virus with this birth defect. And the virus is known to be transmitted from mother to baby, even though the baby is in the uterus still. They have had babies that were delivered and died, and they did autopsies on and found this virus in the brain tissue of these babies. So this is a microcephaly baby. It's kind of a hard picture to see, but as you can see, microcephaly is where the brain is small in size and doesn't develop properly. And with that comes all the cognitive issues that goes along with a retardation of the brain and stuff. Some of these kids can be normal, but most of them have some kind of mental retardation that goes along with this microcephaly. And some microcephaly kids you'll even see, and you can kind of see it on the backside of this kid's head, there's almost dents in their skull because there's just lack of brain. So in terms of the Zika virus, there's no local mosquito-borne Zika virus cases in the US right now, but they have had the travel-associated cases. The Zika cases among travelers visiting or returning to the US will likely increase. And 80% of those people that are actually infected will likely not even be diagnosed because they won't show symptoms. And I'll get to that in a minute. This could cause local spread based on sexual transmission, which we have seen in Texas, or a mosquito biting the person that has the disease, doesn't know it, and then transmitting it to somebody else. So there's been local mosquito-borne transmission in Puerto Rico, U.S. Virgin Islands, and American Samoa, but those are the only countries in the United States as of the current maps that were due to mosquitoes themselves being infected. So as of February 10th, in the United States, it's all travel-associated virus. 52 cases are reported as of the 10th of February. None of those were locally acquired. Those were all transmitted in from travel. In the U.S. territories, there's 1 travel-associated case and 9 locally acquired cases. So you can see there's a little bit difference there. So this is kind of small, but this is the actual transmission cycle. So a mosquito bites, a person gets infected with the Zika virus by being bitten by a mosquito. They then get bit by another mosquito and they transmit it to another person through that mosquito biting that second person. It can also be transmitted through the uterus into the baby in utero, excuse me. Next slide. So the signs and symptoms are these. And this is the reason why 80% of them won't be diagnosed. Only 1 in 5 infected with Zika becomes symptomatic. 1 in 5. And so they're saying actually anybody who's pregnant that travels to the endemic areas should come back and get tested even if they don't have symptoms to see if they have the virus, okay? So the clinical findings are acute onset fever, maculopapular rash, arthralgias, conjunctivitis, which is red eyes, myalgias, and headaches. So there's a picture of the conjunctivitis on the bottom with the bright red eye. On the top is the maculopapular rash, and obviously the other one is is that my phone? It's actually my sister. I didn't even know the ringer was on. Okay, go ahead, next one. The clinical illness is usually mild. This is another reason a lot of people won't get diagnosed with it because they may not even realize what they got. Symptoms lasting several days to a week. Fatality is extremely low. It rarely needs hospitalization. It, however, does have the association with microcephaly, and it does have an association with Guillain-Barré syndrome. Guillain-Barré syndrome is an ascending paralysis where paralysis starts in the feet and starts working its way up and eventually gets to the lungs and causes you to have difficulty breathing. It's a neurologic disorder, can be treated, but it has a lot of long-term side effects in terms of weakness and stuff. And it's very expensive to treat. They treat it with IVIG, which is in the thousands of dollars, usually $60,000, $70,000 a treatment. So go ahead, next one. This is the other thing. Since it has similar distribution and symptoms as dengue and this, I can never say this right, chikungunya virus. So you have to wonder if the person has Zika or if they have one of these other 2 viruses. So in treatment, you have to avoid any kind of NSAIDs until you rule dengue out, which is not exactly the quickest thing in the world because, you know, it's not like you just give the lab to the lab person and they tell you it's not dengue. You know, they're specialized tests. And you want to prevent people from transmitting it to somebody else. So they need to have like long sleeves on or stay out of the area where they could get mosquito bites, those kinds of things. There's really no treatment for Zika itself. It just has to run its course. Like any of the other viruses out there, it's symptomatic treatment. Other than that, you just kind of let it run its course, but the whole idea is to try and stop the transmission at that person 1, and not let it be transmitted out. So the ways to prevent yourself from getting it, especially if we get deployed out, make sure your sleeves are down if it's at the time when there's mosquitoes out, okay? Make sure you keep yourself covered if you're in an area that's endemic to it. Say if you get sent to Haiti again or whatever, make sure you're sleeping in the mosquito nets. And yes, NDMS does have mosquito nets in the caches. I've pulled them out before and put them up. They're interesting to say the least, but they're there. Next topic we're going to go on to real quick is the heroin epidemics. So as you know, heroin's been huge lately. There's been a lot of press on heroin. Ohio is the 2nd leading state in heroin deaths. And I'm doing this section for Scotty, who's not even paying attention. Okay. So between 2002 and 2013, the rate of heroin related overdoses has quadrupled in 2013. 8,200 people died of a heroin overdose. The greatest increase in these are actually in women, privately insured, and people with higher income. So we're seeing this not necessarily in the low income in the inner city. We're seeing this in the white people, the suburbs, those kinds of people. The numbers have more than doubled in the 18 to 25-year-old population. 9 out of 10 people using heroin started by using another drug as well. 45% of these were also addicted to prescription opioid painkillers. Trumbull County, which is the county I came from out on the west or the east side of the state, last week had 11 overdoses and 3 deaths in 2 days. In 2 days. They have a combination of fentanyl and heroin out there, but it was bad enough that there's, this is funny, there's actually a Facebook site called Portage County Heroin Dealers, which is the county over from Trumbull County. And on their website, they posted up a big sign that says, there's a bad batch of heroin out there. Be careful. Don't assume it's the same stuff you've been using before. It's kind of funny that a heroin dealer Facebook page would put that out, but it was an interesting thing to see out there. It's obviously illegal, highly addictive. It can slow and give you slow and shallow breathing, coma, death. Heroin's used along with other drugs or alcohol most of the time. Usually we don't see just straight one, although heroin sometimes we do. It's typically injected but can be smoked, snorted. When they inject the heroin, they're at risk for obviously long-term HIV, hepatitis B and C both, as well as a lot of skin infections. We can see a lot of skin abscesses, especially from skin popping, endocarditis, and just straight bacteremia of the blood. So it's also part of a larger substance abuse problem. As you can see, people who are addicted to alcohol are 2 times more likely to be addicted to heroin. Marijuana is 3 times, cocaine 15 times, and opioid painkillers 40 times. Now, a lot of people blame the physicians and the medical field for prescribing opioids and getting a lot of people hooked. But if you look at the stats from the state, in 2014, which is the most recent data that's out, there were 40 million less doses of prescription pain opioids given in this state alone. 40 million less doses written by physicians. That doesn't mean that there's not people out there overdosing. It just means that they're not getting it as a script from a doctor. They're finding it somewhere else. So the most at risk of heroin addiction are people who are addicted to painkillers. Those who are addicted to cocaine, those without insurance or enrolled in Medicaid, used to be a larger population, although that's shifting. Non-Hispanic whites, males, people who are addicted to marijuana and alcohol, people living in large metropolitan areas. You don't see it as much in the farm fields, although if you look in Ohio at the stats from the state, besides Trumbull County, which for some reason has this huge overdose rate, besides that county, a lot of the counties that have the highest rates per capita are actually down in the south part of the state, right along the Ohio River, like Scotto County and those. And a lot of those have fairly high addiction rates down there. Again, 18 to 25-year-olds as well. Interesting thing is Trumbull County is not inner city Youngstown over there. Youngstown is actually in Mahoning County. So Trumbull County is actually the northern kind of suburbs of Youngstown and another city called Warren, which actually has a higher rate of heroin abuse than the inner city black portion of Youngstown does, which is kind of strange. Mixtures of fentanyl and heroin are being seen in areas and are associated with higher overdose rates, even in people who are used to taking that same amount. So these people who are heroin addicts will take their normal amount of heroin and they'll still overdose from it, and sometimes overdose and die. And it's because, so I have friends that are cops out in Youngstown area, and they actually put out a warning on the news channels that you have to look at the stuff that you got, because there's just such a slight difference in the color that it looks the same between just straight heroin and fentanyl. So they're mixing heroin and fentanyl, and it looks almost the same as the regular heroin. The heroin people, or heroin addicts, are taking the same amount of what they think is just straight heroin, but it's heroin and fentanyl, and overdosing. Some of the places out there have started using up to 6 to 8 milligrams of Narcan on a single overdose. You want to talk about a lot of Narcan? That's a lot of Narcan. Usually just a subtle difference in the heroin color is seen from straight heroin to the heroin and fentanyl. It's like literally a pale yellow versus a white. So it's that close. Narcan, naloxone, is the only reversal agent. Kroger just started selling it over the counter today here in Toledo. It had been sold with prescription before. It's going to cost about $50 to $100 here in Toledo to get it if you're buying it over the counter and out of pocket. The question is, and this is an ethical thing that's come up, do you give it to the people to try and reverse their loved one and try and save them when they have a chance to save them, because they're right there and they have a chance to do it before they become brain dead and aren't breathing and that kind of stuff? Do you give it to the cops, which has been done successfully in multiple counties, including Lorain County, and that's actually where this whole Narcan thing started out of. They gave it to the cops to be the first responders on a scene, and if they got there and they were able to reverse them, they were actually showed significant amount of lives that were saved by earlier administration of Narcan than waiting for EMS. But then there's also the other question of, are people going to use it to just reverse themselves long enough to get out of that state and, you know, just get another high? I don't know. I mean, it's kind of a fence you jump, and it's kind of a hard fence. As a physician, I think I'd rather prescribe it and have them give the chance to save someone's life, because if you're not breathing, you're not giving it to yourself. Somebody's giving it to you. Somebody sober enough is giving it to you. So that means there's got to be somebody else around. I don't know. Okay. So, and then I was asked to do a short EKG review. So this is EKG review. Any ideas what this rhythm is? Not quite, but close. Huh? Yes, it has a pulse. Almost all of these have a pulse. The PR is longer. It's a first-degree AV block. Very good. So what Kathleen was asking me is if this PR, and I'll come up here so you can see where I'm pointing, is longer. Yeah, right there. Nope, over one. That little lump right there. No. That one, yeah, that one or that one, yeah. And the distance from that to the QRS is longer. So go to the next slide. It's longer, and that's actually what causes it to be a first-degree AV block. So your PR interval is 0.28 seconds there, which is longer than the 0.12 seconds that it can be for a normal QRS, okay? There is some ST segment depression. If you look at the rhythm strip, there was a little bit of ST segment depression also following the QRS. So there's a little bit of a depressed segment there. Next one. So this is just second degree type 1 block. I didn't actually put this in separately. I left these together. So second degree type 1 block is an irregular ventricular rhythm with a regular atrial rhythm. Your atrial rhythm is 75 times per minute. But if you look at your PR interval, it starts to lengthen, and each time it'll lengthen until you drop a beat. So lengthen, drop a beat. Next one. So this is sinus tach. If you look at the rate, it's above 100. To be sinus tach, you got to be over 100. You got to have a normal QRS, which means a nice skinny QRS, a PR segment that's, I was right before, 0.2 or less for a PR segment. And your atrial rate and your ventricular rate should match. Next one. Any ideas on this? Conduction delay is probably from the right bundle, yes. There's something else significant on this one as well. No, not on that. But you are right in looking at the ST segment. What does it look like to you? So you got ST depression here, which usually refers to what? Ischemia. Right. You also see this as a reciprocal change for an area that has ST elevation. So this is a sinus rhythm with an ST segment depression and a wide QRS. The wide QRS is probably due to the right bundle branch block, like Kathleen was saying. Your PR interval is 0.18, so that's normal sinus. Your atrial rate and your ventricular rate match, again, making it normal sinus, and it's very regular, but you have that depression of that ST seg. Excellent. So atrial flutter, this is one that catches a lot of people a lot of times. It has this typical sawtooth pattern in between. If you look at the lower strip, that sawtooth pattern is typical for atrial flutter. Atrial flutter can be very regular. It can be 150 or 300. But it can be very regular for your atrial rate, which would make, if you have 150 for your atrial rate and you have a 2-to-1 conduction, which you can have 2-to-1, 3-to-1, 4-to-1 conduction for atrial flutter, but if you have a atrial rate of 150 and you have a conduction rate of 2-to-1, you're going to still have a rate of 75, but you still may be an atrial flutter, but it can be very, very regular, as opposed to atrial fib, which is very irregular. Sometimes it's difficult to determine your actual atrial rhythm and rate, but your QRS is always thin, this 0.08 seconds, but it's also always that nice narrow look. Okay, go ahead. And your QRS gets irregular based on how often it conducts and what time it conducts. Anyone know what this is? Ventricular pacer. I have a lot of people come in, and you may not see these pacer spikes. I put this one specifically because you can see these pacer spikes really, really well. But a lot of times you can't see these pacer spikes really, really well. And I'll have a lot of people come in and say, is this ST elevation? I'll be like, nope, that's just a straight pacer. Once you get a paced rhythm, there's only a few things you can actually tell from the EKG. And it's based on discordance of different segments, but pretty much that elevation of that ST segment, that's normal, and it should always be going the opposite way of the QRS, which is usually going down. So again, your atrial, this one you don't have atrial paced activity, you just have ventricular paced activity, and it's paced at a rate of 65. So go ahead. So this is your typical agonal rhythm, where you'll see a beat or two. Sometimes they'll be 20 seconds apart, 20 beats. They'll pace out to a rhythm of 20 or 30. But essentially, you'll have these individual complexes, and then no ventricular rate, no atrial rate, no atrial rhythm. You'll have no PR interval typically on an agonal rhythm, or because typically it's a ventricular beat that's breaking through. It's typically not an atrial then ventricular beat. Okay, so it's usually just ventricular that you're seeing there. Any ideas what this is? I'm hearing a couple different answers out there. Someone yell it out loud. Okay, so this is VTAC. This is monomorphic VTAC. Monomorphic has a very regular rhythm, and it usually has a ventricular rate, in this case around 214 times a minute, but that's usually what the ventricle, if you count it out, will come out to. In terms of the ventricular rate is usually elevated. It's not necessarily 214, but it's usually elevated. You won't see an atrial rhythm in VTAC because the ventricular rate is just kind of overtaking it, and your QRS will be anywhere from thin to wide. In this case, it was fairly thin. Okay, go ahead. Next one. Any ideas what this one is? Torsades or polymorphic VTAC. Okay, so it's essentially still VTAC. It's just polymorphic, which means it has different shapes, different sizes, and it usually goes from big to small to big. What's the first line treatment of torsades? Anyone remember? Not necessarily. Mag. And then you can shock them if they need it. Or if you're around Jeff, he's going to hit you. So this is second degree block, AV block type 2. So this one is very regular atrial rhythm. Your atrial rhythm is very regular, but your ventricular rhythm is irregular because not every one of those conducts. But in this case, the PR interval does not lengthen. You just drop the QRS. So in the first one, in the type 1, your PR intervals lengthen, lengthen, lengthen. In this one, your PR intervals don't lengthen, but you do drop the beat. Okay? Does that make sense? Okay. And this is atrial fib. This one's atrial fib with a little bit of a wide QRS. You can have atrial fib with a thin, narrow complex, or you can have it with a wide QRS. A lot of times we'll see atrial fib that almost looks like VTAC sometimes. And if you try and treat something as VTAC and it's atrial fib, it won't necessarily correct, okay? Because they're different etiologies and they're different causes for each of those. So you got to kind of take a look. In this one, you know it's atrial fib because it's very irregular. VTAC's a lot more regular. If you look at VTAC, it's usually fairly regular. Whereas atrial fib, even if it's with what we call aberrancy or wide QRS, will oftentimes be irregular, but very subtly irregular the faster you get. So you got to look at it and you got to pace it out, and you got to take whether you take calipers or take a piece of paper and measure it, but measure it out and see if it's regular or not. Again, your ventricular rate can be anything above 100, usually for AFib, RVR. It can be, you can get atrial fib less than 100, and we see it every day. But when we start getting above 100 is when we start getting concerned. There is no PR interval because there is no P wave in atrial fib, and your QRS is usually fairly thin, but you can get wide ones. Any ideas? It's bad. Thanks. Thanks, Buford. Now, Jeff, now you might want to shock them. All right, this is, go ahead, next slide. Your normal VFib. It doesn't have a ventricular rhythm. It doesn't have a ventricular rate. It doesn't have an atrial rate. It's just a big squiggly line. And that's as close as you're going to get before going to flat line, which was in an earlier slide. Any questions on those EKGs? I don't even know what time it is. Ooh, I went through that pretty quick. Huh? Any questions on anything that I put up there today? The Zika. Usually the virus only stays in you for about a week and a half after getting exposed. But in that week and a half, yeah, you can You can, and there's actually cases in Texas where, and actually there's older cases from before where there was a wife that was in Colorado, never went out of Colorado. The husband went on a business trip, came back, and she broke out with the symptoms from it. And there's a recent case in Texas where, again, the person didn't leave the state of Texas, but, you know, Colorado being kind of more even distinct in that it doesn't have as much in terms of the mosquitoes, but recent one in Texas, actually in the last couple of weeks, where the husband went down to somewhere in South America and came back and transmitted to her. So if you have loved one traveling to these areas, don't have sex with them for the first 2 weeks after they're back. In the semen, yeah. I was going to say the suggestion of the Brazilian Health Organization to their women is to not get pregnant until 2018, which is a long time. So. From what? Yeah, most of them are, all of them are transmitted. Those numbers that I have there are only the most updated ones that CDC has out, which is February 10th. They don't have anything more recent than that. Some of that I think is included in there because I know when I pulled up the map, Ohio was on that map as an infected state. I know there was one in Summit County and there was another one in Cleveland. But yeah, so there are transmitted cases. Well, I guess it doesn't matter if you're not trying to get pregnant. So if your wife's not trying to get pregnant, we're good. No, not unless you're having sex with someone that's fertile. Any other questions?